Hey, my name is Lakin Smith, and for my Module 5, I'll be doing my case presentation. Mr. S is a 68-year-old married Caucasian male who lives at home. Access barriers to care were not expressed when questioned, as patient can drive himself to appointments. He does have good family support and good health insurance. His chief complaint was, "I'm just not myself." History of present illness. The patient is a 68-year-old pleasant Caucasian male with a past medical history of diabetes mellitus type 2, hypertension, hyperlipidemia, and benign prostate hyperplasia. He presents today because he just does not feel like himself. His wife states he has had bouts of confusion and agitation, and he has been feeling fatigued for the past 3 days. His wife also states that these bouts of confusion and agitation are expressed as confusing rooms of the house and becoming easily agitated with any minor inconvenience. According to his wife, nothing exacerbates the symptoms or hastens them, and after 3 days of symptoms, his wife finally called to make an appointment to be seen. Pertinent positives for Mr. S include intermittent confusion, agitation, frequency, urgency, fatigue, and malaise. Pertinent negatives include dyspnea, angina, abdominal pain, neck pain, nausea, vomiting, diarrhea, vision changes, and numbness. His past medical history was per his HPI. His past surgical history includes a cholecystectomy 14 years ago. His family history includes skin and colon cancer with hypertension. His social history: he's a former tobacco user, 2 cigars a day for 40 years, and he is an occasional beer drinker. His allergies: no known drug allergies or no known food allergies. His medications: he takes metformin 500 mg POBID, Flomax 0.4 mg POQD, Zocor 20 mg QPM, and lisinopril 10 mg POQD. His review of symptoms were per his HPI, and as I'm about to mention, his HENT: he denies ear, eye, and throat pain. GI: denies change in bowel habits and melena. GU: denies dysuria and hematuria. Lymph: he denies abnormal bruising, bleeding, and lymphadenopathy. Neuro: he denies headache, syncope, and recent seizure. Objective: his vital signs: pulse 84, blood pressure 129/75 supine, respirations 14, saturation 98% on room air, temperature 97.9 oral, and pain 0 out of 10. His general appearance: he is a well-developed male in no distress. HEENT: normal cephalic, atraumatic. Pearly was noted. He had bilateral pearly tympanic membranes, pearly gray tympanic membranes with no erythema or drainage to the ear canal. His turbinates were pink. Thyromegaly was not present. He had no erythema or edema to the oral mucosa, and no lymphadenopathy was noted. His trachea was noted to be midline, and his lungs were noted to be clear to auscultation. His heart: normal sinus rhythm, S1, S2 noted, no gallop, rub, or muffled heart sounds. Abdomen was soft to palpation, no tenderness or distension. He had normoactive bowel sounds times 4 quadrants. No mass is palpable, and hepatomegaly and splenomegaly were not noted. GU: patient was noted to be uncircumcised. No edema or erythema or discharge noted. Suprapubic tenderness was noted upon palpation. His extremities: there was no edema to any extremity, and he was able to ambulate independently. Neuro: so he had negative neuro findings, and he was awake, alert, oriented. Labs: his hemoglobin was 13, hematocrit 39.2, white blood cells 11, platelets 209, creatinine 0.9, BUN 22, K, or his potassium 3.9, sodium 140, hemoglobin A1C 6.2, UA, the color was dark yellow, appearance was clear, and bacteria was seen, and it was nitrite positive. Upon an ultrasound, no hydronephrosis or stones were present. Differential diagnosis: dementia. Supporting data would be confusion, fatigue, age. Negating data would be sudden onset, frequency, and urgency. Pyelonephritis. Supporting data: pain, frequency, urgency, fatigue. Negating data: flank tenderness, fever, dysuria, nausea, and vomiting. Prostatitis. Supporting data would be history of BPH, frequency, fatigue, and suprapubic pain. Negating data would be testicular pain, dribbling, fever, and dysuria. So the diagnosis was a UTI, and the supporting data was confusion with his age, Frequency, urgency, history of BPH, suprapubic pain, the UA results of bacteria and nitrites, and he was not circumcised. Urinary tract infections are among the most frequent problems within medical practice. Bacteria is usually the source of infection, and it's through the digestive system and its waste. And E. coli is recognized as the most common bacteria responsible. And with UTIs, you'll have irritative voiding symptoms such as frequency, urgency, and dysuria that are common, and they may or may not be present with a low-grade temperature, fatigue, and malaise. Upon physical exam, the patient may exhibit suprapubic tenderness when palpated, and in the elderly, usual symptoms might not be present. For example, behavioral problems such as confusion may be exhibited. The connection between the elderly and confusion with UTIs is well established, although the etiology is unknown. My reference for this section would be Hooten, 2018, Ming, Walsh, and Kai, 2019. Although UTIs in men are uncommon, patients with existing comorbidities such as diabetes, prostate issues, neutropenia, and autoimmune disease are more susceptible to serious infection. Culture is recommended in men with suspected UTI. Treatment of UTIs is usually identical for men and women, usually Keflex, Macrobid, Bactrim, or Monurol. In men with concerns of prostate involvement or other comorbidities, fluoroquinolones are warranted, specifically Cipro, 500 milligrams BID times 5 days, or Levaquin, 750 milligrams for 5 days, once a day, or 7 days. Infections normally respond very quickly to these therapies, and failure to response of treatment may be indicative of resistance or structural abnormalities, and further investigation is often warranted. Plan, interventions, and competencies. I will give education regarding proper hydration through tertiary and primary prevention and expert guidance and coaching. I will give education regarding infection control such as wiping and hand washing through primary prevention and expert guidance, coaching, and consultation. I will prescribe Cipro to treat the infection, and that's secondary prevention through expert coaching and guidance. I will give education regarding taking newly prescribed Cipro as directed, which will be tertiary prevention through expert guidance and coaching. I will give education regarding a follow-up visit if symptoms do not resolve. That is tertiary prevention through expert guidance and coaching. I will give a referral back to the patient's known urologist regarding a follow-up on the BPH if symptoms persist, and that is through tertiary prevention and collaboration. So I will refer the patient to the emergency department if the fever above 100.4 is not responsive to Tylenol and Motrin, which would be tertiary prevention through collaboration. And I will give education regarding signs and symptoms of sepsis. That is tertiary prevention through expert guidance and coaching. Mr. S's flexible lines of defense has been penetrated by the UTI stressor. The normal line of defense is Mr. S's usual state of wellness. This normal line is hindered when the flexible line of defense is broken and the stressors are allowed to further act upon the body, sending Mr. S into periods of worsening states of wellness, which would be evidenced by confusion, malaise, fatigue, frequency, urgency. This normal line of defense can change and cope with the environment. It can wax and wane dependent on treatment efficacy and compliance. Anytime the normal line of defense is broken related to the stressors, the line of resistance is involuntarily activated. This line tries to stabilize the client system and attempts a return to normalcy or restoration of the normal line of defense. When the line of resistance cannot reestablish or restabilize and further complications arise, death is imminent. Mr. S's line of resistance can stabilize once more with a positive response to treatment of the UTI with Cipro and proper hydration. Ineffectiveness of the line of resistance on reversing the stressor will continue to penetrate the system through failed response to treatment or further complications that arise like urosepsis and will ultimately lead to death. My reference for this section is Newman, 2011. The stressors for this case presentation are as listed as follows. Physiological intrapersonal. Negatives are polyuria, frequency, suprapubic pain, fatigue, hematuria. Afebrile would be a positive, and confusion would be a negative. Physiological interpersonal would be a family history of skin, colon cancer, and hypertension. They would be negative. Physiological extrapersonal, a positive, would be a good support team. Psychological intrapersonal, a positive would be he was cooperative with the assessment and with questioning. And a negative would be reported confusion outside of the office. Psychological intrapersonal, a positive would be a good support system. Psychological extrapersonal, another positive would be a good support system. Sociocultural interpersonal, a positive would be that he's a Caucasian male. Sociocultural intrapersonal, a positive would be he has a good active relationship with his wife. Sociocultural extrapersonal, a positive would be he has a good support system again. Developmental interpersonal, a positive would be he has a college degree in business. Developmental intrapersonal, a positive would be he does have weekly breakfast with his friends. Developmental extrapersonal, once again, a positive would be a good support system. Spiritual interpersonal, spiritual intrapersonal, and spiritual extrapersonal, a positive and a negative at the same time for all three of those would be that he attends church sometimes. So the hypothesis is if Mr. S takes his Cipro as prescribed and proper hydration is practiced, and he performs proper genitourinary hygiene and hand washing, Mr. S's symptoms will diminish completely by the arranged follow-up appointment in 5 days. Mr. S and his wife were both involved in generating this plan of care, and together we composed a plan on how to adequately treat and inhibit this infection in the future. We examined ways to limit problems and future occurrences, such as adequate hydration, appropriate hand washing and wiping, taking medications as prescribed, and the importance of annual visits with the urologist if one is diagnosed with urinary problems. Also, we had discussed going to the emergency room if a fever above 100.4 is non-responsive to Tylenol or Motrin, as well as the signs and symptoms of sepsis. And a follow-up appointment was arranged in 5 days to re-examine Mr. S. Mr. S's symptoms will respond adequately without any further complications if the urinary tract infection hypothesis is correct. I will reevaluate Mr. S in 5 days to re-examine for further monitoring. Symptoms should be improved upon the 5-day follow-up, and I will follow up with him in 3 months after this visit if symptoms resolve for his routine lab work and exams. Mr. S's symptoms will not resolve if the urinary tract infection hypothesis is incorrect. If Mr. S has not improved, I will re-examine in 5 days for further evaluation regarding lab work and possible medication changes and possibly hospitalization if his symptoms worsen. References for this Module 5 include Hooten, 2018, Acute Simple Cystitis in Men, Newman, 2011, The Newman Systems Model, and Ming, Walsh, and Kai, 2019, Urologic Disorders.